Hello everyone, this is James at GasGasGas. Welcome to another episode where we're going to discuss volatile anaesthetics a little bit and then consider how administering them to achieve and maintain and emerge from anaesthesia can be compared to the ever-exciting compartmental model. I think this is a good way to open the door to thinking about pharmacokinetics for TIVA. And also it's a model that you can actually directly fiddle with and manipulate in order to get more of a feel about A, how volatiles work, but B, to get your mind around the concepts of multiple compartments and the interactions that occur within them that subsequently yield the effects that drugs have on humans. So a little bit more about Sevoflurane. In the UK it seems to be the most commonly used volatile inhalational anaesthetic. It has friends, chiefly isoflurane. It's cheaper, but it takes longer to wear off. It's also a little bit more irritant and smells not so nice, so not really your best choice for a gas induction. Its other friend, which was perhaps far more commonly used a few years ago, is desflurane. Des, well loved by the archaic dinosaurs of multiple departments, I'm sure, wears off a teensy bit quicker, but may or may not kill polar bears, / its equivalence in CO2 is astronomical, and you have to use more of it for the same effect. I think generally on paper, if you do the maths, sevoflurane at low flow anesthesia rates works out to be the least bad of isoflurane, sevoflurane, desflurane. When you're thinking about volatiles, you have the delight of multiple parameters and numbers which influence how it behaves in a physical environment, i.e. when it boils, when it might become a liquid, what its saturated vapor pressure might be, and then there's some more words. Blood gas partition coefficients, i.e. how it behaves between lungs and blood, or oil gas coefficients, which I imagine this is how it behaves between brain and blood. And those are important numbers, and you have to get a bit of a feel for how they behave in relation to one another, i.e. is desflurane more oil gas partition coefficient-y than sevoflurane? It's stuff you kind of have to go and learn to have a ranking in your head of what's what. Now for that time in the podcast where someone asks us an awkward question and we have to think about how to approach it. Hello, Doctor. This is your pharmacology minor. What influences the onset time of volatile anaesthetic agents? Okay. There are many factors that influence the onset of volatiles. I break this down into circuit and ventilatory factors and then patient factors. So considering the circuit, onset time is reliant on the concentration of anaesthetic delivered to the patient, as well as the amount of fresh gas administered to that circuit. It's dependent on the size of the circuit and presence of any leaks within that circuit, i.e. the fewer leaks and the smaller the circuit, the faster the onset time. It's also influenced by patient lung factors, so the size of their FRC, the alveolar minute ventilation you're delivering, i.e. have you minimised dead space, as well as the patient's cardiovascular state, i.e. their cardiac output. It seems almost contradictory in that a lower cardiac output actually yields a faster onset of anaesthesia. This is considered due to slower flows across capillaries facilitates diffusion of agent from plasma into effect site. Another factor to consider with the circuit is the presence of a second gas that would facilitate uptake. Then I like to think about factors within the patient that may influence the amount of agent required to achieve depth of anaesthesia. Factors which increase the amount of anaesthetic required. On a spectrum, the younger the patient, classically the more agent is necessary. If they are in a anxious or increased state of catecholamine activity or sympathetic nervous system activity, if they are hyperthermic, hypernatremic, or if they are a chronic user of alcohol or opiates and their basal neuronal excitatory state is higher because they've abstained from those two agents for their anaesthetic. Situations that reduce MAC requirements are almost the opposite here. So older patients need less agent, if they are hypothermic or hyponatremic, if they're pregnant, as well as if they are critically unwell, i.e. hypotensive, septic, their anaesthetic requirements are less. And also if there's presence of synergistic agents on board, so if the patient's acutely intoxicated or has taken a number of opiates, benzos or tricyclic antidepressants, you can find that they require less anaesthesia. There are a number of drugs that we may introduce to the patient that would also reduce MAC requirement or anaesthetic dose requirement. Classically consider these as sedatives, so opiates, alpha-2 agonists, as well as magnesium and some drugs that they may be prescribed like antipsychotics and lithium. And then there are factors based around the agent that you choose. Some anaesthetic agents have faster or slower onset times. This is governed classically by the blood gas coefficient, the lower the better, and the oil gas coefficient, which the higher the better in the context of rapidity of onset. So, Doctor, you mentioned that FRC plays a role in onset time of volatile anaesthetic. Why is this? I like to think about this as a situation with volumes and concentrations. So, in a patient with a high FRC, functional residual capacity, you find yourself in a situation where you have a greater volume of lung that you need to maintain a high concentration of anaesthetic agent in. This is critical because the concentration of anaesthetic agent in the lung could be sometimes considered equitable with the concentration in the brain. Now, this is perhaps slightly not accurate during induction of anaesthesia because of the rapidity of uptake from the lung and deposition into the target tissues. Having a smaller functional residual capacity means that the total volume of lung that you are seeking to achieve an anaesthetic agent concentration in is lower. Therefore, you can maintain a higher concentration and achieve onset of anaesthesia quicker. Okay, yes, thank you. Moving on. So that's a potential exam question. They may also think about asking about what the second gas effect is there. That can be a little bit of a minefield because there's some confusion there to be had that you need to work your way through. They may also wish to talk about oil and blood gas partition coefficients, or they might want to talk about particular factors with patient age or frailty and onset time and safety, i.e. what's the difference between managing a frail NOF patient versus a fairly robust 10-year-old who's having their tonsils out. So that was an example. We've talked about lots of different factors there, and there's clearly no time in this podcast to go through everything. You'd just be tired and bored of hearing my voice. So I'm going to focus on a few things, ones that bamboozled me. Definitions of things. Blood gas partition coefficient. I imagine this as the willingness of the sevoflurane that you've got into someone's lungs to stay in the plasma. And this begins to illustrate compartments. We're going to describe 3 compartments briefly here. Lung, plasma, effect site, brain. If you have a low blood gas partition coefficient, the sevoflurane does not want to be in the blood. It hates its life when it's in there and it's really miffed. But it has no choice but to go in the blood if the lungs are full of 8% sevoflurane and there's 0% sevoflurane in the blood. So it has to go there. However, at the first opportunity, it wants to leg it. So it's dumped in the blood and it leaves the lungs. And now that plasma full of 8% sevoflurane, although it'll be a bit less because there's a concentration gradient, remember, is being pumped off around the rest of the body, mucho rapido, and it's going to wang past the brain, kidneys. There's going to be some perfusion of the heart through the coronaries, perfusion of the lungs through those bronchial arteries, and other important tissues that are vascular. The more vascular you are, the more blood you get from that cardiac output squeeze, that stroke volume. So now that blood full of mostly sevoflurane has been fired off to the brain, and the brain has no sevoflurane in it, and the sevo's like, thank hecking God, I don't want to be in this blood. I'm much happier in a bit of brain. And it goes into the brain. This is why having a low blood gas partition coefficient, i.e. having lower solubility, yields a faster onset, because it just doesn't want to be in there. The next partition coefficient is the oil gas partition coefficient. This is the ability of the agent to dissolve into fat. Now, you'd think if it dissolves into fat, great. The more it wants to jump into the brain, which, as you know, is quite a lot of fat, myelin, etc., floating about, the faster the onset time. And it is. A higher oil gas partition coefficient, i.e. the more lipid soluble the agent is, the faster the onset time is, because it wants to get out into tissues. The trouble arises when that partition coefficient is so high, you basically fill that patient with agent, and then it's got to come out again. You can use the oil gas coefficient as a surrogate for potency, i.e. the lower that number, the less the potency is. You can see this working when you compare desflurane and sevoflurane. So desflurane, oil gas partition coefficient 29, sevo 80. So to achieve the same depth of anesthesia, you need proportionally more desflurane than sevoflurane. And you can see this because the MAC, i.e. the end tidal sevo concentration required to keep 50% of patients wriggle-free with a standard incision, the MAC of DES is 6.6% of their expired gases, whereas the MAC of SEVO 1.8. So you need much more DES to achieve the same, to maintain the same depth of anesthesia, because the brain soaks up plenty. If the brain soaks up plenty, getting the concentration high in the brain is harder because more of it fits. Now, I'm very excited to talk to you about the delights of a real hands-on compartmental model that you can fiddle with as an anaesthetist to your heart's content. You can measure it through surrogates and truly begin to understand A, how drugs get into people, and B, how they come back out again. Super cool. One of my favourite things to think about. And that is the patient who is induced, maintained, and emerges from a volatile anaesthetic. And we'll take the example of a 8-year-old child having a gas anaesthetic for dental anaesthesia, because that's probably where you're going to be doing a number of gas anaesthetics. So I like to think about this as multiple compartments all chained together that yield interesting things. These are the circuit, so your circle circuit. Sometimes you might be using a Mapleson D to induce your anaesthesia, or a Humphreys ADE if you're really feeling cool and old-fashioned. So you've got a circuit, and I consider this volume or this compartment up to the airway device. And then I think about the airway device, i.e. your face mask, then it might become your eye gel or tube, and consider the dead space in that device plus the patient's dead space. Next compartment, the patient's lungs, naturally. Next compartment, the patient's blood, and also you need to think about how much blood is going past those lungs. And then their brain, their heart, kidneys, liver, their muscle, and then their fat space. So here we are. We've got little Tommy. Tommy has come in and he's taken one look at that cannula and he's on the ceiling, but he needs his teeth out because they're awfully rotten. Mum agrees that, yeah, let's get on with it and do a gas anaesthetic, and we start wafting some gas at Timmy. And you might be thinking we're in the 1950s and we're going to clamp that mask on Timmy's face, but we're not. We're going to waft that mask at him with maybe some nitrous because we hate polar bears, and subsequently some anaesthetic gas. Number of factors influencing onset time here. If you're wafting and you're not getting a seal, then they're going to get less dose. So you're filling the room with nitrous and volatile. So you need to think about the atmosphere very adjacent to that child's face and go fairly high on the flows. It'd be sensible to open with nitrous and bamboozle them a little bit and then introduce the SEVO slowly. As you do this, you can then slowly creep that mask closer, get that mask over their face, and off we go to sleep. Now, if Timmy's wailing and howling and starts crying, taking huge lungfuls, that increases the dose, but also increases their cardiac output because they're upset, and increases their stress response because their sympathetic nervous system activates, they're terrified, which slows your onset time. Tricksy. So now we're going to assume that we've got a sealed face mask attached to the patient, and now that they're exhaling gases that also contain sevoflurane and nitrous that also returns to our circle circuit, we now can increase the concentration within our circuit compartment and speed up our onset, because we can actually reuse some of that agent and know that we're delivering a higher concentration of agent to the child. We've got a face mask, so now we're just thinking about the dead space within that mask cavity and the dead space between, his lips and his alveoli. And he keeps chunching away, breathing, because they naturally tend to breathe when you do a gas induction. However, his breathing then changes and it becomes quite rapid, quite shallow, and his airway gets noisy because he's in that excitatory phase whereby he's getting some agent, it's gone to his brain, it's anaesthetised some of him but not all of him, and he's making that descent into the depths of anaesthesia. Sometimes you might think about an airway adjunct at this point, but they're excitable. You could cause the rhingospasm and make your life very awkward, especially when you've not got a cannula in little Timmy currently. So you've got to grizz it out, sat there knowing that their shallow, rapid breathing means that actually they're just ventilating a lot more of their dead space and a lot less of their alveoli, which isn't helpful, but you've just got to grizz it out and keep going with high concentration agent. Then he dips into that lovely deep anaesthesia. His breathing slows down, his airway gets less noisy, he gets more relaxed with lower tone, and you either stick an airway device in at this point or cannulate and propofol and stick an airway device in. So now we know that we're in a state where we've got good concentrations in our circuit, good concentrations in our lungs out into the depths of his alveoli, and likely sufficient concentrations in his noodle that are giving us a decent depth of anaesthesia. However, whilst he's got some blood going to his brain delivering anaesthetic agent, he's also got blood leaving his brain carrying anaesthetic agent elsewhere, and the brain will want to equilibrate with the rest of the body. If you were to stop delivering agent at this point, just give them oxygen, they will actually quite rapidly wake up because they're going to clear agent through their lungs back into the circuit. They're going to pick up high concentrations of agent from their brain and distribute it around to the rest of their body, i.e. we're dropping the effect site concentration, and they're young because Timmy's having his teeth out and he's 10, so actually he needs quite a lot of anaesthetic agent to keep him asleep. We don't want that. So you have to keep maintaining a fair dose of volatile at this point in time, knowing that there's lots of re-equilibration of agent that's going to occur, and you want to land into that nice sweet spot whereby you're giving just about enough agent to maintain anaesthesia, and get your flows down, and feel very smug. Admittedly, if it's mental dental, it's probably quite a short anaesthetic. Anyway, I've just talked loads and really enjoyed that, but actually it wasn't really the example I wanted to give. Gosh, I've got carried away. Okay, so I've explained how induction with gas might occur. Gosh, that was a tangent. Right, so let's go to another case and talk about cruising altitude with volatile anaesthetics. So here we are, it's 8 p.m, you've just finished your IAC and you're off to anaesthetise your first appendix, and they're a fit and well 24-year-old lad, and you've decided propofol induction with a bit of fentanyl, maintenance with volatile, and then wakey at the end, and you're going to intubate them. So you've given them propofol, you've given them fentanyl, you've paralysed them, you've conducted some sort of modified RSI, and you've intubated them, and you've whacked up the Sevo, and you're in the anaesthetic room, and you're thinking, oh, shall I put a temperature probe in, do I want another cannula, and all those sorts of things. We're going to assume that you've gone for 5% Sevoflurane, you might have gone for 6, with maybe a fresh gas flow of 8 litres. And you might tweak it down so it's not all oxygen, but some air as well, so you avoid the harms that pure oxygen have to the lungs. What do you see? Well, the patient starts soaking up that volatile, like you might expect. Hoovering it up because you've got a lovely concentration gradient between the lung and the plasma. And you think, tickety-boo, great, let's go into theatre. So you turn off the circuit, turn off the fresh gas flow, turn off the Sevo, and off you go into theatre. And then you get into theatre having thought, well, you know, my end tidal's 3.5, my MAC was 1 and a bit, yeah, I'm fine. And you get them into theatre, attach them to the new circuit, turn on the gases to those rates and concentrations, and actually you realise your MAC's 0.6, your end tidal's 1.8, and you're thinking, oh, God. This is because you've got a fit young gentleman who has re-equilibrated between his various internal compartments during that trip from anaesthetic machine number 1 in the anaesthetic room to anaesthetic machine number 2 in theatre. We're recalling that when you are giving a nice concentration, a lot of it goes to the brain, and then often a portion of that's blown back out, a portion ends up in other tissues in the body like muscle, and some is eking out into the fat, although only a little bit, because there's a sort of a fixed rate of how much ends up in the fat depending on how much is in the plasma and the cardiac output. So you sorted that out, you cranked up the Sevo, You made sure no one was poking or prodding the patient too much. And, if you find yourself in this situation and the MAC is very low, you could give a little bit of extra propofol just to make yourself happy. We're back to a sensible situation. The surgeon's scrubbing up. You've tucked the patient in, connected them all up, checked the monitoring, and you're happy. And you're running your Sevo at 4%, and you've come down from your 8 litres of gas flow to your 4 litres of gas flow. You try and start writing your notes because you're desperate, you don't want to forget anything of what you've done, and you look up and there's another dip. And this is because you're delivering the same concentration, or maybe a bit of a lesser concentration of Sevo, but I like to think about it, 4% of 8 litres is quite a lot of drug, whereas 4% of 4 litres is less drug. You need to titrate this to the individual patient because they're all different shapes and sizes with different cardiac outputs, and you tweak up the concentration, knowing that you'd rather not use the fresh gas, and hopefully you can find that sweet middle ground. His MAC is still 1, and you're happy with that. So you start writing your notes proper, the surgeon's fiddling around, and they've insufflated the abdomen, and it's all fine. And then you look up, and you realise that the patient's got a MAC of 1.5, and you're like, hang on, what's going on there? You've done a very good job of filling the patient. You've filled up their brain, their heart, their lungs, their muscle stores, and you've started filling up their fat stores. And now you're eking agent into their fat, and the rest of it is accumulating in the plasma, which means when they exhale a higher concentration, and that is what the MAC is derived from. So you tweak down the flows and you go to 400 mils or so, and get back to doing your notes. You look up again 20 to 30 minutes time, and that damn pesky MAC is up at 1.5 again, despite coming down on your flows and presumably delivering the right amount of agent. And this is because at this point in time, and you'll see it, you've actually filled up their fat stores now with volatile, or at least got very near to filling their fat stores. This means that you now have the plasma filling up because the Sevo can't go anywhere else. So you have to come down even more. You could come down on your concentration. You could edge down your fresh gas flow a little bit further. Patients need at least 250 mils of oxygen per minute. And here we are, and they're flopping around with the appendix. It's stuck to the liver, the cecum, and they're not quite sure where it is. So they're faffing and prevaricating for a reasonable period of time as you're sat at maximal cruising altitude with filled brain, heart, lungs, liver, muscles, fat stores, and plasma. Great, you think. I can use very little anaesthetic now because it's all in the patient. And you're right. With Sevoflurane particularly, about 3 to 5% is cleared by the liver. The rest only comes out when you breathe it out. You need to account for any losses in your circuit through leaks or scavenging. And at this point, it might be sensible to make sure your alarms are nice and tight so that you can keep your flows low and not miss anything going a bit pear-shaped. And then the surgeon turns around and says, I'm all done. And you're thinking, oh, crap. Because now you know that you've got a patient who is exceedingly full of Sevo. And that means they're going to take ages to wake up. So you've now need to think about ways to influence the situation in order to speed waking. Because you don't want to be sat around for hours, you need a coffee. So you turn off the Sevo, you ramp up the fresh gas flows. Naturally, you check to make sure the patient's not paralysed, etc., etc. A number of situations can occur here to think about from a compartmental perspective. So you ramp up the flows and turn off the Sevo. So now you're recreating a concentration gradient in the opposing direction. A minimally Sevo-ish set of lungs and a highly Sevo-filled patient means that it's going to start coming out again. There are things you can do to influence how quickly that does. You don't want the patient to be inhaling any Sevo, so you keep your flows up. You might turn up your respiratory rate and maybe creep up your tidal volumes ever so slightly in order to increase your alveolar minute ventilation. This means that the lungs spend a greater amount of time with a lower concentration of Sevo in them, therefore facilitating elimination through the lungs. And you think you're doing great because that MAC rapidly starts plummeting. It's pouring down, and you get yourself to 0.2, thinking, this is great, actually. Maybe I've got away with it. Patient's going to wake up, going to get coffee. Going to be great. You think you're king of the world. However, you get stuck at the classic 0.2 MAC. And here is the situation. You have cleared Sevo from all the highly perfused bits of this patient. So there's a bit in their brain now. There's a bit in their muscle. But mostly, they're fairly empty. They're not completely empty because we find ourselves in a situation of irritating, equilibrating compartments within the patient. The offender is the fat store, chiefly. This is because it is full of Sevo. it might be there's quite a lot of Sevo in there, and there is a rate of clearance from that compartment that is slow enough that it's boring, but sufficient enough that it means that you're depositing Sevo to the plasma that then gets distributed to the lungs, but also back to the brain, back to the muscle. So this is your rate limiting step. And you can get stuck there for a very boringly large amount of time. There are things you could do to try and speed things along, but you need to bear in mind that you've basically got like a depot injection of Sevo in the patient, and it's going to keep emptying until it's empty. And the patient's always going to be a bit anaesthetised until they're not, i.e. once the fat stores are empty, the patient is going to wake. You could hyperventilate them at this point, and you may find that you can achieve a higher elimination rate from the plasma than the clearance from this fat store to the plasma. The patient might stir a bit and you think, this is great. Unfortunately, the patient isn't breathing as quickly as you're making them breathe, and they're just going to re-equilibrate back to being dozy. All patients are different. Some you might be able to safely extubate at this point in time, others you might not. That's the nuance of anaesthesia and emergence. Volatiles are a great way to think about compartments. The important thing to know is that there are the excitable phases on falling asleep and waking up that can trigger laryngospasm if you're not careful. We also know that if you're frail and old, giving someone 8% Sevo is probably a recipe for quite a lot of paperwork. And there are things you can do to while away the time when your patient is waking up from 0.2 Mach to point awake Mach. And what I like to do is repeatedly look at their eyeballs, because it's quite hilarious. It always makes me chuckle, and you can see them descend from depths of anaesthesia to wakefulness, which is an excellent example of the planes of anaesthesia that you need to learn about, from, like dilated, staring ahead, injected looking eyeballs to squints of convergent and divergent and wonky eyeballed natures that then come back to the midline with pupils that are now a bit smaller and a bit more normal looking. It's always funny to look at what their eyes are doing whilst you're whiling away the time. So, this is a long one actually. I might cut some bits out of it because I've got carried away. But we've talked about Sevoflurane. We've compared and contrasted in brief some of the volatile agents. Talked about the factors that influence onset, some factors that influence offset, discussed what a gas anaesthetic might look like and how those compartments are behaving then, and then cruising altitude anaesthetic in emergence and how compartments behave then. We've also covered partition coefficients, which are important. You've got to learn them. You might even have to learn the numbers depending on how you're feeling. And the crux of all this, this is a compartmental model that you can actually fiddle with and influence based on the equipment and style of anaesthesia that you choose to apply, and it's an excellent way to think about compartments, which you're going to have to do for TEVA. Fun times. Thank you very much for listening, guys. This was James with GasGasGas, and I hope that you're going to have a nice day today. Enjoy.